If you are a man over the age of 60 and you are waking up 2, 3, or even 4 times every single night to go to the bathroom, I want you to know something important before we go any further. What you are experiencing is not simply an unavoidable consequence of getting older. It is a medical condition. It has a name, Nocturia, and it has identifiable causes, well-documented mechanisms, and proven strategies to reduce or eliminate it. The reason millions of men accept Nocturia as a permanent feature of aging is that nobody has ever sat down and explained to them exactly what is happening inside their bladder and prostate at night, why it gets worse with age, and what specific targeted interventions can change it. That is what I am going to do for you in the next 16 minutes. I am Dr. James Whitaker, board-certified urologist with over 22 years of clinical practice, specializing in lower urinary tract dysfunction, benign prostatic hyperplasia, and male pelvic health. I have treated thousands of men with Nocturia, and the pattern I see in clinical practice is consistent and deeply frustrating. Men come in after years of disrupted sleep, exhausted, irritable, sometimes dangerously fatigued, having never been given more than a prescription for an alpha blocker and a vague recommendation to reduce fluid intake in the evening. Most of them have never been told about the pelvic floor mechanism that directly regulates urethral closure pressure at night. Most of them have never been told about the role of antidiuretic hormone in nocturnal urine production and how its secretion changes after 60. And virtually none of them have been shown the specific 10-second physical technique that I teach every new patient in my practice. A technique that can be performed in bed without getting up, that takes 10 seconds to execute, and that for many men dramatically reduces the urgency signal that wakes them up at night. Let me start by telling you about Martin, a 68-year-old retired engineer who came into my clinic 18 months ago. Martin was waking up 4 times every night to urinate. He had been doing this for 3 years. He was so fatigued from the cumulative sleep deprivation that his wife had become genuinely worried about his safety driving. His previous physician had prescribed tamsulosin, an alpha blocker, which had modestly reduced his urgency, but had not reduced his nocturnal trips below 3 per night. Martin had tried cutting off all fluids at 6 p.m. He had tried avoiding caffeine entirely. He had tried sleeping with his legs elevated. Nothing had reduced his nocturia below 2 to 3 voidings per night. When he came to see me, I identified 3 separate contributing mechanisms that had never been addressed simultaneously, and I taught him the technique I am about to describe to you. Within 6 weeks, Martin was waking up once per night at most. Within 3 months, he had 4 consecutive nights of sleeping straight through. His wife called my office separately to tell me that she had her husband back. To understand why the 10-second technique works, you need to understand what actually happens in the body when the bladder sends a nighttime urgency signal. The human bladder is a muscular organ whose wall contains a layer of smooth muscle called the detrusor muscle. When the bladder fills to a certain volume, approximately 200 to 300 milliliters in a healthy adult, the detrusor muscle begins generating stretch receptor signals that travel to the brain and are interpreted as the urge to urinate. In younger men, the brain can easily suppress this urge for hours. The suppression mechanism works through the pudendal nerve, which maintains tonic activation of the external urethral sphincter, the voluntary muscle that physically holds the urethra closed, and simultaneously sends inhibitory signals back to the detrusor via the pontine micturition center, reducing the urgency sensation. This is why healthy young men can feel an urge to urinate and simply choose to wait. After the age of 60, this suppression mechanism deteriorates for several reasons that I will explain shortly. But the key point for understanding the 10-second technique is this. The urethral sphincter and the pelvic floor muscles that surround it have a direct neurological reflex connection to the detrusor muscle called the guarding reflex. When the pelvic floor is actively contracted, when the external urethral sphincter is squeezed firmly, neurological feedback through the pudendal nerve inhibits detrusor contractions reflexively. The urgency signal is temporarily suppressed, and this reflex can be deliberately activated by the patient in bed the moment they feel the nocturnal urgency sensation beginning. The 10-second technique works as follows. The moment you wake up feeling the urge to urinate, before you sit up, before you put your feet on the floor, before you begin the process of physically going to the bathroom, you perform a rapid, firm pelvic floor contraction. Not a slow squeeze, but a quick, forceful contraction of the pelvic floor muscles, held for 3 to 5 seconds, then released briefly, then repeated 2 or 3 times in rapid succession. The total execution time is approximately 10 seconds. What this does, physiologically, is activate the guarding reflex at the precise moment when the detrusor is beginning its involuntary contraction that is generating the urgency sensation. The neurological inhibition sent back to the detrusor interrupts the urgency wave before it reaches its peak, and in many men, particularly those whose nocturia is driven primarily by overactive bladder and detrusor instability rather than by overflow from an obstructed prostate, the urgency sensation subsides sufficiently to allow return to sleep without voiding. This technique is not a cure. It is a management tool, and its effectiveness depends on the underlying cause of the nocturia, which is why understanding the full picture of why nocturia develops after 60 is so important. There are 4 primary mechanisms that drive nocturia in men over 60, and in the majority of men, 2 or more of these mechanisms are operating simultaneously, which is why single drug treatments so frequently produce incomplete responses. The first mechanism is nocturnal polyuria, the overproduction of urine specifically during nighttime hours. In healthy adults, the body produces a hormone called antidiuretic hormone, ADH, also known as arginine vasopressin, that suppresses urine production during sleep. ADH secretion follows a circadian pattern, rising significantly in the late evening and remaining elevated through the night, which is why healthy people can sleep 8 hours without needing to urinate despite drinking fluids throughout the day. After the age of 60, ADH secretion, particularly the nighttime surge, declines substantially. The result is that the kidneys continue producing urine at near daytime rates throughout the night, filling the bladder continuously rather than allowing it to rest. A man who produces 40% of his daily urine volume during the 8 hours he is asleep has nocturnal polyuria, and for this man, the bladder is not abnormal. It is simply being filled too quickly by kidneys that have lost their nighttime suppression. Nocturnal polyuria is present in an estimated 60 to 80% of men over 65 with nocturia, making it the single most common contributing mechanism. It responds to specific interventions: compression stockings worn during the day to reduce the venous pooling in the legs that redistributes as fluid overnight, an afternoon nap with legs elevated, reduction of sodium intake, and in selected cases, low-dose desmopressin, a synthetic ADH analog, prescribed by a urologist. The second mechanism is benign prostatic hyperplasia, BPH, the age-related enlargement of the prostate gland that causes partial obstruction of the urethra as it passes through the prostate. When the prostate enlarges, the urethral lumen narrows, and the bladder must generate higher pressure to push urine through the obstruction. Over years, the bladder wall hypertrophies. It thickens in response to this increased workload. A thickened, hypertrophied bladder wall is stiffer and has reduced compliance. It cannot expand as comfortably as a normal bladder wall to accommodate filling urine, and it reaches its urgency threshold at lower volumes. A man whose bladder previously triggered urgency at 350 milliliters may, after years of BPH-related detrusor hypertrophy, experience urgency at 150 to 200 milliliters, meaning his bladder needs to be emptied at twice the frequency for the same overnight urine production. BPH is present in approximately 50% of men at age 60 and over 80% of men at age 80. Its treatment ranges from lifestyle modification and alpha blockers to 5-alpha reductase inhibitors that actually shrink the prostate over months, to minimally invasive procedures including urolift and resume water vapor therapy, to traditional surgical options including TURP for severe cases. The third mechanism is overactive bladder, a condition characterized by involuntary detrusor contractions that generate urgency sensations even at low bladder volumes, in the absence of infection, obstruction, or other obvious pathology. Overactive bladder is driven by changes in the neurological control of the detrusor muscle, specifically, a reduction in the brain's inhibitory control over the detrusor as the frontal lobe and basal ganglia undergo age-related changes. The prefrontal cortex is the primary brain region responsible for voluntarily suppressing the urge to urinate, and its ability to send inhibitory signals to the pontine micturition center, the brainstem region that coordinates the urination reflex, declines with age, with cardiovascular disease, and with early neurodegenerative changes. This is why urgency and urgency incontinence increase in prevalence so dramatically after 60, and why men with early cognitive decline are particularly vulnerable to severe nocturia. The fourth mechanism is sleep-disordered breathing, specifically obstructive sleep apnea, which contributes to nocturia through a mechanism that most men and most primary care physicians are completely unaware of. During apnea events, when the upper airway collapses and breathing stops, intrathoracic pressure swings dramatically negative as the respiratory muscles strain against the closed airway. These negative pressure swings stretch the right atrium of the heart, which interprets the stretch as a sign of fluid overload and responds by releasing atrial natriuretic peptide, ANP, a hormone that signals the kidneys to produce more urine. Additionally, the sympathetic nervous system activation that accompanies each apnea event causes a brief arousal that the brain may interpret as an urgency signal, sending the man to the bathroom when the true need is not urinary, but neurological, the consequence of a breathing event. Studies have consistently shown that treatment of sleep apnea with CPAP reduces nocturnal voiding frequency by 50 to 70% in men whose nocturia is primarily driven by this mechanism. If you snore loudly, if you have been observed to stop breathing during sleep, or if you wake from sleep feeling unrested despite adequate duration, please discuss sleep apnea testing with your physician before assuming your nocturia is purely a prostate or bladder problem. Now let me give you the complete management framework that I use with patients in my clinic, the framework that produced Martin's result and that has helped hundreds of my patients reduce their nocturia to 1 or 0 nighttime voidings. The first intervention is the 10-second pelvic floor contraction technique I described at the beginning of this video. Practice it during the day to develop the muscle awareness and strength required to execute it effectively at night. Perform sets of 10 rapid contractions, each held 3 to 5 seconds, 3 times daily. Within 2 to 3 weeks, most men develop sufficient pelvic floor strength and neurological awareness to execute the technique reliably when awakened by urgency. The technique is most effective for nocturia driven by overactive bladder and detrusor instability. It is less effective for nocturia driven purely by nocturnal polyuria, because in that case, the urgency signal is accurate. The bladder genuinely contains urine that needs to be expelled. The second intervention is afternoon leg elevation. If you spend significant time sitting during the day, watching television, working at a computer, reading, fluid accumulates in the veins and tissues of the lower legs due to gravity. When you lie down at night, this accumulated fluid redistributes into the circulation, increases blood volume, and is filtered by the kidneys as additional urine over the subsequent 2 to 3 hours. Elevating your legs for 30 to 60 minutes in the early afternoon, lying on the sofa with your legs propped higher than your heart, mobilizes this fluid earlier in the day when you are still awake, reducing the nighttime fluid redistribution and the resulting nocturnal urine production. A 2014 study published in the Journal of Urology found that afternoon leg elevation combined with compression stockings reduced nocturnal urine production by an average of 21% in men with nocturia and dependent edema. The third intervention is precise fluid timing. Cutting off all fluids at 6 p.m., as many men attempt, is counterproductive if it results in excessive thirst and compensatory drinking earlier in the day that still loads the kidneys with excess fluid. The optimal approach is to front-load fluid intake. Drink the majority of your daily fluid requirement between waking and 3 p.m. Taper fluid intake gradually between 3 p.m. and 6 p.m., and limit intake to small sips after 6 p.m. Target total fluid intake of 1.5 to 2 liters daily, adequate for kidney health but not excessive. Avoid alcohol after 6 p.m. entirely. Alcohol suppresses ADH directly, dramatically increasing urine production in the hours after consumption, and is one of the most potent drivers of nocturia in men who drink in the evening. The fourth intervention is a discussion with your urologist about whether desmopressin is appropriate for your situation. Desmopressin, a synthetic version of ADH, is now available in a low-dose formulation specifically approved for nocturia in adults, and multiple randomized controlled trials have demonstrated its ability to reduce nocturnal urine production by 30 to 50% when administered at bedtime. It is not appropriate for all men. It carries risk of hyponatremia, low sodium, in men over 65 with certain cardiovascular or kidney conditions. But in carefully selected patients, it is one of the most effective single interventions available for nocturia driven by nocturnal polyuria. Martin's outcome came from addressing all 4 mechanisms simultaneously. The pelvic floor technique for his detrusor overactivity component, afternoon leg elevation for his nocturnal polyuria component, alcohol elimination for his ADH suppression, and a urology referral that ultimately led to a Urolift procedure for his BPH component. No single intervention alone would have produced the result we achieved together. Nocturia in men over 60 is almost always multifactorial, and it responds best to a multifactorial approach. If you are waking up 2 or more times every night, please do not accept this as your fate. Request a comprehensive urology evaluation. Keep a bladder diary for 3 days, recording every void, the volume, and the associated urgency level, and bring it to your appointment. The information in that diary will tell your urologist far more about the mechanism driving your nocturia than any single test or questionnaire. You deserve uninterrupted sleep. You deserve the energy and health that comes from genuine rest. And with the right information and the right clinical support, you can get it back. Please share this video with every man over 55 in your life who is dealing with disrupted sleep. Leave a comment below telling me how many times per night you currently wake up and whether you have spoken to a urologist about it. Like and subscribe for weekly urology health content. I will see you in the next video.